Good evening, everyone. I will be doing my final presentation on the principles of surgical management of thoraco-lumbar, particularly lumbar degenerative disease and lumbar back pain. So I'll be looking at the surgical treatment of lower back pain and lumbar degenerative disease, focusing on laminectomy and its fusion options, the procedure of choice, the complications of laminectomies, the treatment or the surgical treatment of spondylolisthesis. We'll talk about minimally invasive spine surgery decompression, or MISS, the difference between a laminectomy and a laminotomy, and the failed back surgery syndrome. So surgical indications in patients with a radiographically identified herniated disc that would correlate with findings on the history and physical exam would actually include if there was failure of the non-surgical management. Also, if the patient is in need of emergent surgery, as I would have mentioned with in the last two classes, emergent surgery would be indicated by Thoraco-Lumbar syndrome, acute development, or progressive motor deficit, or what we would consider urgent surgery, where the patient has pain that's intolerable in spite of adequate narcotic pain medication. And we may also perform surgeries because of patient choice. And these are in patients who don't want to invest time in a non-surgical treatment, and if it's possible, that they can get the surgery. Once we have decided on the surgery or to treat surgically, the options would include the transcanal approaches. So that would be the standard open lumbar laminectomy and discectomy. The microdiscectomy, which is pretty similar to the standard procedure of the laminectomy, but on a smaller incision. The advantages of this procedure would be that it's for cosmetic purposes, shortened hospital stay, and lower blood loss. The disadvantages is that it may actually be more difficult to retrieve some of the fragments of the spine in the spinal canal or of the spine. But the overall efficacy of this procedure is very simple, similar to a standard discectomy. And then lastly, sequestrectomy, and that's where you have removal of only the herniated portion of the disc without entering the disc space to remove the disc material. Now, when you have discs that herniate beyond or lateral to the foramen, you can also use the traditional midline hemilaminectomy, and that would allow you to gain access to the region from the lateral side to the dural sac without under retraction on the nerve root or the chordae equina. You can also have the lateral approach, and that is through a paramedian incision, and that's an alternative technique to just remove the lateral portion of the superior articular facet below. If you have an intradural disc herniation, you can use a dural opening to relieve pressure. On the screen, I would have also listed some conditions and the surgical treatment options. So as I would have just mentioned, the disc herniations, if you have a foraminal or far lateral HLD or herniated lumbar disc, you can use a partial or total fasciectomy. You can also use some endoscopic techniques. For lumbar spinal stenosis, you can also use a simple decompressive laminectomy or laminectomy plus fusion, which I would talk about later on. Lumbar spinal fusion is usually and most widely accepted as part of treatment for a fracture dislocation or instability resulting from a tumor infection. I just chose to include that because I realized I did not mention certain tumors and infections of the spine in my previous slides. You can also have the intradiscal surgical approach or ISP procedures, and that's where you actually create a cavity within the disc itself. Now, this is done under local anesthesia in order to permit or allow the patient to report in real time nerve root pain so that we would be able to identify the impingement on a nerve by the surgical instrument or needle. This treatment is not usually recommended until rigorous control trials prove the efficacy. The advantages of this procedure would be epidural scarring is avoided, you have a small incision or even just a puncture site, and you can also have a reduction in post-operative pain and hospital stay. The issues with this is that it's directed at removing the disc material from the center of the disc space, which is not producing any symptoms. And it also relies on the reduced intradiscal pressure to decompress the herniated portion of the disc from the nerve root. So now I'll focus on a laminectomy. So in a, forgive me, sorry. The procedure of a laminectomy is usually takes between 1 to 4 hours, depending on the extent or the complication of the patient. The patient is usually put in a prone position. The abdomen should be made free of any undue pressure. We should then localize or anatomically localize our structures. Then the superficial tissue and muscle dissection is done to reach the spinous process. After that, we have the subperiosteal dissection of lamina, but not exceeding the axis of the facet joints in a classical laminectomy, and not exceeding the tip of the transverse process in others. Now, the spinous process removal is next by a large rongeur or a horsley bone cutter. And then after that, we have the removal of the lamina via the lexal rongeur, starting from the interlaminar space. After that, we have removal of the thickened ligamentum flavum, followed by, well, plus or minus use of a high-speed drill to thin the lamina, followed by its removal via the Currington can, and After that, we have undercutting of the medial facet and decompression of the respective foramina. Then lastly, we can have layered wound closure after ensuring we have hemostasis and plus or minus replacement of a drain. So the options that you have in terms of fusion for a laminectomy would include posterior lateral fusion plus or minus pedicle screw or rod fixation. I have it on the screen here. And then you can also have interbody fusion. And interbody fusion would include the posterior lumbar interbody fusion or PLIF and the transforaminal lumbar interbody fusion or TLIF. The interbody fusions are not generally or not usually done as a standalone, and they usually would also require some stabilization. And the options would include using facet screws, facet dowels, spinous process clamps, or pedicle screws. Now, we also have procedures that would increase the disc space height and thereby indirectly decompressing the neural foramina without direct decompression. And they would include the anterior lumbar interbody fusion or ALIF through laparotomy. You also have the lateral lumbar interbody fusion. And some techniques in this group are trademarked as extreme lateral and direct lateral. And then you have the axial lumbar interbody fusion, and that particularly only happens at L5 to S1. And lastly, you have limitation of extension by interspinous spacer or plates / decompression. Forgive me, sorry. On the screen on the right-hand side of the image just shows the advantages and disadvantages of the different fusion techniques. So for instance, the anterior lumbar interbody fusion, the ALIF, would it avoids the spinal canal, it achieves better lordosis. Fusion is very similar and it doesn't really have much major complications. So this image just shows us the different approaches as well as some cartoon images of what the fusion surgeries would look like. So to your top left, you have the anterior lumbar interbody fusion with its device. Down below, you have the direct lateral interbody fusion. So interbody fusion. So you can see it's entering the vertebral bodies from the side. Then you have the transforaminal lumbar interbody fusion right here. The posterior lumbar interbody fusion, which would be this one here. And then the axial lumbar interbody fusion, which takes a very, very inferior approach through the coccyx up to S1 and up to S5. This treatment on the screen it basically explains the limitation of extension by interspinous spacer. So other spacers, alternatives that you can see on the screen on your right-hand side. So the first one is called a promise The second one is called a rocker. The two that I found were very interesting were E, which is this one here, the Superior, and this is said to be a valid alternative to laminectomy in a well-restricted population of patients that are usually affected by one or two levels of lumbar spinal stenosis. However, it is something that you need to tell patients that it has a high rate of possible reintervention. The other one that I found was very interesting was G, which is this one, which is the Aperius. And these are all just different devices produced by different companies, particularly in the US. The Aperius was the first percutaneous titanium ISD or interspinous device available on the market. It was designed to be used as a standalone implant. There have been good outcomes and at least a 6-month follow-up in patients with no migration of device reported as yet. Now, interspinous spacers particularly, they would limit extension at least one or two levels without fusion, thus preventing narrowing of the associated neural foramen. And it may also be, the benefit of them may also be to offload the facet joint and even the disc. Now, the interspinous plates, they usually clamp across two spinous processes to fixate them, unlike the, forgive me, unlike the one I mentioned before, which limits extension. Interspinous plates may be used to augment other constructs, like the lateral interbody fusion, and they're not intended for standalone like the interspinous spacers. Now, the contraindications for using these devices, when you have instability at a level considered for procedure like spondylolisthesis greater than grade 1 or scoliosis with a curve angle of greater than or equal to 25 degrees, quad-equina syndrome, acute fracture of the spinous process, when you have bilateral pars defects, osteoporosis, and osteoporosis, sorry. Also, when you have an ankylosed level that was already fused, as well as it's not really indicated in patients less than the age of 50, since there was no investigation for treatment done on them. Now, we have something called motion-preserving spine surgery, and this basically encompasses a range of techniques designed to alleviate pain and restore function while still maintaining the natural mobility of the spine. Unlike traditional spinal surgeries or fusion surgery, which aim to immobilize the affected spinal segment, the motion-preserving procedure prioritizes preserving the movement, flexibility, and range of motion. On the screen, I have approximately three different devices. The first one is the artificial disc replacement, or ADR, and that actually involves replacing a damaged or degenerated intervertebral disc with an artificial implant that basically would mimic the function of a natural disc. This innovative approach actually allows for continued motion at the treated spinal level, reducing the risk of adjacent segment degeneration. In the image here, the first one, this is called an in-motion ADR. The second one is a charite, number 3, and then C is a ProDisc 2. Secondly, we have the dynamic stabilization, and this system tries to employ specialized implants that would be here, specialized implants that would stabilize the spine while allowing controlled movement. It utilizes rods made of flexible materials to stabilize the affected level of the spine. These devices are particularly beneficial for patients with conditions such as degenerative disc disease or spinal stenosis, where maintaining the mobility of the canals of the spine is crucial. And then lastly, we have facet replacement, which would be on the right. And this involves replacing the damaged facet joints with prosthetic implants designed to preserve spinal motion. This procedure actually offers an alternative to fusion for patients with facet joint arthritis or instability. Now, I would have just mentioned an array of procedures that can be done. And now I will talk about how do we go about choosing which procedure according to the defect. So we use indirect decompression. So that would be the lateral interbody fusion, the ALIF, or the interspinous decompression /plates or devices. One, when the foraminal stenosis appears to be the dominant problem, when previous spine surgery that might make exposure to the nerves more difficult or risky. And lastly, when the disc space is compressed, so that is if the disc height is normal, it is actually difficult to achieve indirect decompression by further distraction. We would use direct decompression or laminectomy when we have pinpoint or severe canal stenosis, especially when the disc height and neural foramina are well preserved, when there is a significant contributor to the compression and it is focal, a focal correctable lesion like a herniated disc or synovial disc or intraspinal tumor. And we also use direct decompression to avoid a fusion in particular cases. Now, the motion preservation surgery, we would use it when a fusion is undertaken at a level and the adjacent level is already starting to show some form of degenerative changes. And these changes have not yet reached a surgical magnitude or a point where we should intervene surgically. It is at the motion preservation at this adjacent segment theoretically shields it from some of the transmitted stresses from the fused level. When do we use fusion? We use fusions in situations where we have spondylolisthesis, especially those greater than grade 1, symptomatic sagittal imbalance or degenerative scoliosis, dynamic instability on flexion and extension of lateral lumbar spine x-rays. We use them with the expectation that the decompression would stabilize the spine. Also, we use them to multiply recurrent. When we have multiple recurrent herniated disc, when this is a third or more operation on this for the same disc. And what is also controversial is something called a black disc on an MRI. And that's where you have a positive concordant discogram at this level. Fusion with the decompression has been advocated when there's no neural compression. So these would be complications that we would usually put on formal laminectomy. We would usually put on our forms for most of our, well, all our patients that come into hospital for elective or emergency surgery. So the common ones would be infection. They can either be superficial with an incident rate of 2.3 versus deep, which have had an incident rate of 5.9. Increased motor deficit. So we always tell patients that the role or the aim of the procedure is not to remove the pain, but to stop the degeneration or the progression of the disease, or to try our best to. Incidental durotomy, that happens in approximately 0.32 to 13% of patients. Recurrent herniated lumbar disc, the same level on either side, and post-operative urinary retention. Some rare complications would be direct to neural structures, injury to structures anterior to the vertebral body, some rare infections, quadratic syndrome, and complex regional pain syndrome. So how do we manage or treat surgically spondylolisthesis? So it depends on the nature of the spondylolisthesis. If it's degenerative, and the problem was a nerve root compression within the confinements of the spinal canal, we do decompression. If it's spinal stenosis, it includes spinal stenosis at the level of the spondylolisthesis. We do decompression, and sometimes we would do an intertransverse process fusion. And lastly, if it's a nerve root compression far lateral or outside the confines of the spinal canal, we'll do a radical decompression, which is a Gill procedure. And a Gill procedure is just a procedure and its modifications that consist of radical decompression of the nerve root, including the removal of the loose posterior elements and total fasciectomy. If the nature of the spondylolisthesis was traumatic, we usually just do a decompression plus fusion. So a minimally invasive procedure is one that merely is a less invasive than a normal laminectomy or spinal surgery. The goals of an MISS is to give the same outcome as an open surgery, however, with less pain, fewer complications, and shorter recovery time. Some of these cases can be performed via a surgical incision as small as 1 inch. Now, inclusive of shorter recovery times and improved functions associated with this type of procedure, the other benefits I would have mentioned would be shorter hospital stays, reduced risk of infection, reduced post-surgical pain and narcotic use, less blood loss during surgery, less damage to soft tissue, reduced scarring, quicker return to activities of daily living, including work, self-care, and leisure, less post-operative rehabilitation, and basically a better post-operative quality of life. Now, let me go to the next slide. So I would have just mentioned a laminectomy and a laminotomy, right? And this is performed in cases where the central canal has a normal AP diameter, but the lateral canal gutter is stenotic. I'll go to the other slide for a better picture. So let me see if I can zoom in here. Right. So a laminotomy would remove a portion of the lamina, as we can see here, the bone at the back of the spinal canal, and so through a small opening that is created, sometimes enough just to take the pressure off the nerve. And then when you have a laminectomy, you have removal of the entire lamina, and this helps relieve pressure when a disc bulges into the nerve. So you can see the difference in the area here. So back out. So this just shows us how basically we go about booking lumbar discectomy or lumbar laminectomy plus or minus fusion or stenosis. And in both of these cases, we would just basically consent the patient, explain to them how the procedure would be done and what devices we might be using. Now, surgical failure can be actually divided into two groups. Patients with initial improvement who develop recurrent difficulties. Although short-term improvement after surgery is common, many patients actually progressively deteriorate after time. And then you have patients who fail to have any post-op pain relief, Something that I found interesting was failed back surgery syndrome. And this is where you have failure to satisfactorily improve low back pain or radiculopathy following back surgery. Now, these patients often require analgesia, a lot of analgesia, and unable to return to work. So most of the patients who we see in our NIS clinics would fall into this category. The failure rate for lumbar discectomy to provide satisfactory long-term pain relief is between 8 to 25%. Now, factors that may cause or contribute to the failed back syndrome may be incorrect initial diagnosis. So if it is that we may have had inadequate pre-op imaging or the clinical findings are not correlated with the abnormality that we see on the imaging. If the patient had continued nerve root or chordaequinal compression, and this can be residual compression caused by retained disc material or osteophytes. They have some recurrent pathology at that same level, like disc herniation that may occur. If they have adjacent level pathology, so again, they may actually have disc herniation and stenosis, compression of a nerve root by a peridural scar granulation tissue, epidural hematoma, discitis, spondylosis, whatnot. Some patients may also have non-atomic factors, so poor patient motivation, secondary gain, so they would be gaining some form of relief if it's by coming to see us more often, medication and whatnot, drug addiction or psychological problems. And that is the end of my presentation.